chapter 26, urinary system, starting off with a little bit about renal physiology. We talked about nephrons, their anatomical parts, and how they contribute to producing urine. The three main functions performed by those neurons: first one, glomerular filtration; second, tubular reabsorption; and third, tubular secretion. The first one happens in the glomerulus. That's why it's called glomerular filtration. Pressure forces the filtration of waste-laden blood into that glomerulus. The glomerular filtration rate, which can be measured, is the amount of filtrate formed in all the renal corpuscles of both kidneys each minute. And you actually put out a lot of filtrate, but your body reabsorbs most of it. Tubular reabsorption is, and don't get confused by the name, which at first I did, but that's the process of returning stuff that's in the kidney nephrons essentially back into the blood or back into the body. Tubular reabsorption. The blood reabsorbs some things like glucose, for example. And then tubular secretion is when the opposite happens, movement of waste materials from the blood into the filtrate. Okay. So, the average adult, the body's entire extracellular fluid volume is filtered about 12 times per day. Your kidneys, your nephrons do a lot of work for the day. And we can't lose that much fluid every day. So what happens at the nephrons? Majority of that fluid is reclaimed, reabsorbed, with only a small portion exiting in the urine. This shows 3 steps, and the 3 steps are represented by the 3 arrows here in a more simplified image of a nephron. This is the renal corpuscle, this is the renal tubule, and the following collecting duct. So filtration, glomerular filtration goes from the blood into the nephron. Further on, we skip the tubular capillary. I really like this image, by the way. It gives us the story, the complex story, in a really compact image. Makes it simplifies it. And then the second step, tubular reabsorption from the fluid inside this nephron back into the blood. The tubular secretion from the blood back into the fluid. And what's left is the urine. This just shows a chart of the amount of urine that's produced each day. 1 to 2 liters. Look here, though, the water. The amount of filtrate produced each day is 180 liters. So if we go back here, 180 liters are pushed from the blood into the glomerular capsule. But we only excrete 1 to 2 liters. That means a lot of it is reabsorbed. We usually have 0 glucose in normal urine, a little bit of protein, some urea, which is good, and creatinine. What controls filtration is essentially 2 opposite hydrostatic forces or osmotic forces that push water in and out. Actually out in this case, and we'll talk more about that when we get to advanced physiology. But all you need to know right now is it's forced out via pressure in that capsule. So you have to calculate, we will calculate the net filtration pressure, considering hydrostatic pressure, blood osmotic pressure, and some other pressures. So here's the glomerulus. Again, we're talking about fluid moving from the blood out this area. And the total amount is due to net filtration, pressure, the total amount. Again, the filtration membrane, renal filtration there. Because it was right now. Tubular reabsorption is this step here, so it's returning stuff back to the blood that's good, that your body doesn't want to lose, that your body needs to hold on to, something like water and glucose, that it's pushed out via pressures. Okay? Pretty much the only things that aren't pushed out are things too big to pass. So the good stuff that's reabsorbed, glucose, electrolytes like sodium, vitamins, water, amino acids, or any small proteins that might have snuck through. 99% of the filtrate is reabsorbed. 99%. And most of it happens even before it leaves that proximal convoluted tubule in the front. Here we go. Again, look here. 180 liters is filtrated out. Amount returned via reabsorption, 178 to 179 liters. That's crazy. Protein, 2 grams pushed out, 1.9 taken back in. Interesting to note, urine can become up to 4 times more concentrated than blood plasma. All this detailed physiology about the nephrons, what we're going to talk about right now. Sometimes, if higher than normal amounts of a substance are present in the filtrate, there's something called a renal threshold for absorption. It may be surpassed, so what happens, it cannot be reabsorbed fast enough, like excessive amounts of glucose, for example, and it's going to be excreted in the urine. For example, again, glucose, the threshold is 180 to 200 milligrams per deciliter. If it's higher than that, like in diabetes mellitus, glucose will spill into the urine, which is not normal and might indicate diabetes in this case. The third step, tubular secretion, further on in the nephron, movement of substances from the capillaries into the nephron waste. It occurs in the proximal convoluted tubule, also the distal convoluted tubule, and the collecting ducts. And active transport is responsible for this, so some energy is involved. Tubular secretion specifically controls pH by getting rid of hydrogen, ammonium ions, if the acidity of the blood needs to be decreased. Bicarbonate is conserved. So substances that are usually secreted are hydrogen ions, potassium ions. So the drugs, and it just depends on, I guess, what the body needs, because it can be different at different points in time. Why does the body's pH, or what helps control the body's pH? Is cooperation between the lungs. The lungs eliminate carbon dioxide. Impacts pH. This provides a rapid response. The kidneys eliminate these ions, and they keep the bicarbonate. This is a slower response, hours or days. Also contributing to the pH of the body, digestive system, and the skin, the integumentary system. A little bit about hormones. We talked about these in the endocrine system. The antidiuretic hormone, which is released from the posterior pituitary, like we talked about. In response to low blood flow, it will be released, so low blood pressure. What happens? It affects water reabsorption by increasing the permeability of cells in the last part of the distal convoluted tubule and the collecting duct. In the absence of that hormone, they're almost impermeable to water, meaning you're going to have more urine output. So antidiuretic hormone makes you hold on to more water. And then this pathway, we'll talk more about here, but little brief synopsis. The secretion of hormones angiotensin II and aldosterone are tied to one another. So when blood volume and blood pressure decrease, or the sympathetic nervous system is stimulated. So you want to increase the blood pressure is what your body wants you to do. The walls of the afferent arterioles coming to that glomerulus are stretched less. So they indicate in that juxtamedullary apparatus that the blood pressure is low. Those cells in that juxtamedullary glomerular apparatus secrete a hormone called renin. That renin that clips a 10 amino acid peptide, angiotensin, and changes it to angiotensinogen. Wait, no. Clips it off from angiotensin. And then what happens? Enzymes called ACE abbreviated converts that angiotensin 1 to angiotensin 2 active form of the hormone. And what happens as a result of the production of that active hormone is to increase blood pressure. So vasoconstriction decreases the glomerular filtration rate, increases blood volume by causing more water to be reabsorbed, more electrolytes to be reabsorbed in that proximal convoluted tubule, and stimulates the cortex tubules of us, which are going to cause cells in the collecting ducts to reabsorb more sodium and chloride, which is going to increase your blood pressure. And here's just a synopsis of the events. Increases in glomerular filtration rate usually result in increase in urine production, but there's many complex controls that are also involved. Normal urine output per day is 1 to 2. Urinalysis is the process of analyzing urine with physical properties, chemical, microscopic properties to assess somebody's health or a diagnostic technique for a disease. Most of the urine volume is water still in there, most of the urine. Solutes normally present in the urine are filtered and secreted substance that last step are not reabsorbed back into the blood. If the disease alters your metabolism or kidney function, we're going to be able to see that in the urine. There's like bacteria, too much protein will be ended up in the glucose. White blood cells, red blood cells. Also, in the besides assessing urine, they can look at blood tests to adequately assess renal function. Blood urea nitrogen, called the BUN, measures the nitrogen waste in blood. They're a product of catabolism and the deamination of taking breaking down the amino acids. Fat levels here in the blood due to catabolism of creatine phosphate, the skeletal muscle. So